Sophia, is my voice clear? Can you hear me loud and clear? Okay, so let's proceed. So first, the anatomy of the pancreas. Okay, so there's the head, which includes the uncinate process. So the uncinate process is the one hugging the blood vessels. Okay, there's the neck, which is portion anterior to the superior mesenteric vein. Body lies to the left of the neck, forms posterior floor of lesser sac. Then the tail, which is adherent to your splenic hilum. So when we do surgery of the tail of the pancreas, it's very technical that we will not remove the spleen. So we do also splenectomy at the same time. Okay, so the resection of the head of the pancreas requires the resection of the duodenum because the head is very adjacent to your duodenum. Of course, there are the ducts. The ducts of the Versang, which is the main duct, which runs entire length of the pancreas and joins common bile duct to form the ampulla. Okay, at within the papilla of water. Then there's also the accessory duct, which is the duct of Santorini. Sphincter of body, of course, if there's a duct, there's a sphincter which controls the opening and closing of the duct. Okay, it surrounds the ampulla. Okay, these are the variants with regards to the pancreas. Heterotropic pancreas, meaning there's a wrong location. There's another pancreatic tissues outside the pancreas. Okay, sometimes it's in the stomach, duodenum, or sometimes it's in the mucous diverticulum. Pancreas divisum. Okay, common question. Failure to fuse the two ducts, which is the ducts of Santorini and the ducts of Versang. Your ducts of Versang is the main duct, but in this pancreas divisum, the duct of Santorini becomes the main duct. Okay. Annular pancreas. Okay, so annular pancreas is common in pediatric patients. The ventral pancreas malrotates and circles the second portion of the duodenum, causing an obstruction of the duodenum. When you request for an X-ray of the abdomen, there's the presence of the double bubble sign, which is due to the annular pancreas. And pancreas composed of the exocrine and endocrine. Mainly the exocrine, which is 85% of the pancreatic volume, while endocrine pancreas account only for 2%. Okay? The rest are matrix and vessels or ducts. Let's go first with the exocrine, okay? So it secretes 1 to 5 liters per day of isosmotic fluid with sodium, potassium, similar to that of plasma. There's the acinar cells which secrete the enzymes, okay? Then the centroacinar and ductal cells which secrete water and electrolytes. This picture shows you the arterial supply of the pancreas. Mainly the arterial supply of the pancreas is coming from your celiac trunk and your superior mesenteric artery. Okay? So multiple arcades in the head and body of the pancreas provide a rich blood supply. Then the head of the pancreas cannot be resected without devascularizing the duodenum unless a rim of pancreas containing the pancreatico-duodenal arcade is preserved. So that's the reason why if you will resect the head of the pancreas or the duodenum per se, okay, you should resect both. Okay, you cannot resect just one. You have to resect both because of the blood supply. Okay, this picture shows you the venous drainage from the pancreas. So the venous drainage of the pancreas follows a pattern similar to that of the arterial supply. Okay, so veins usually is superficial to the arteries. Tear traction of the transverse colon can tear fragile branches along the inferior border of the pancreas, which then retract into the parenchyma of the pancreas. Then venous drainage draining the pancreatic head and incident process enter along the right lateral and posterior sides of the portal vein. So there are usually no anterior venous tributaries, and a plane can usually be developed between the neck of the pancreas and the portal and superior mesenteric vein. Okay, so there's usually a plane when we are dissecting the pancreas from your superior mesenteric veins and portal veins. Okay, once there's no already plane, there's the mass is already adherent to your superior mesenteric vein and portal vein. The mass is pancreatic mass is already considered unresectable. Okay, so there should be plane. So let's talk about the different phases where your pancreas stimulates. Okay. First, the cephalic phase. Okay, the stimuli here is the sight, smell of food, which activates vagal fibers. Okay, so just by sight and smell alone of food, there's already activation or release of secretin. Okay, then if there's an actual ingestion of food, there's the gastric phase. Okay, through if the antrum is distended, okay, and protein, there's also protein because of the food ingested, gastrin will be released. Okay, then gastric acid secretion, duodenal acidification, then secretin also will be released, causing the release of pancreatic bicarbonate. Then after gastric, of course, the intestinal phase will follow. Okay, duodenal acid and bile stimulate secretin, and duodenal fat and protein release cholecystokinin. Okay, so the cholecystokinin is located in the duodenum, which releases pancreatic enzymes, and of course the release of bile coming from your gallbladder. Okay, the concentrated bile coming from your gallbladder. Secretin is the most, as you can see, in all phases, secretin is the most potent endogenous stimulant of bicarbonate secretion. Okay, let's proceed. We're not through with the exocrine. Let's proceed with the endocrine part of the pancreas. So, islet of Langerhans make up 1.5% of pancreas by weight. The hormones are insulin from beta cells, glucagon from alpha cells, pancreatic polypeptide, and somatostatin from delta cells. So this somatostatin is the one controlling or inhibiting functions of GI. Okay. We also give somatostatin or somatostatin analog like octreotide if we have want to decrease the secretions of the GIT. Okay, and also decrease if we want to decrease the bleeding in your GIT. We give this somatostatin or somatostatin analog. Okay, let's go with the first pathology of the pancreas, which is very common pancreatic pathology, which is acute pancreatitis. Okay, so pancreatitis is an inflammation of the pancreas due to the parenchymal autodigestion by proteolytic enzyme. Okay. So what are the causes? Okay, we have this pneumonic pancreatitis also. So posterior perforation of the peptic ulcer, alcohol, neoplasm, cholelithiasis, renal disease, ERCP also could induce pancreatitis, anorexia, trauma, infections, toxins, incinerations, surgery, or scorpion bite. Okay. But the two most common causes of pancreatitis uh, are gallstone pancreatitis due to gallstone and due to alcohol. Okay, so for the gallstone pancreatitis, it's actually not established yet, but there are different uh, theories postulated. First is the most common, which is a common channel hypothesis. Since there's a common channel of the biliary tree and pancreatic duct causing pancreatitis. So there's also the colocalization theory. Okay, these theories are in your book, I guess, or you can find it in the Bloomgard's book of hepatobiliary. So colocalization theory is a more acceptable theory with regards to gallstone pancreatitis. Okay, then alcohol-induced pancreatitis. Okay, so you need to ask your patient if your patient came from a drinking spree. Okay, then suddenly your patient complains of severe epigastric pain or the back. But also you have to ask the, the quantity, okay, the quantity of alcohol your patients is taking, okay, for the past 10 years. So the significant amount of ethanol in at least 2 years up to 10 years, the significant amount is 100 to 150 grams of ethanol. Okay, so remember that, class. So the alcohol to be consumed, in order to be significant, it should be 100 to 150 grams of ethanol, and the time frame should be at least 2 years up to 10 years. Okay, so remember that, class. Okay, let's proceed with the signs and symptoms. Okay. The pain in acute pancreatitis is very severe, okay, and it's located in the mid-epigastric or sometimes onto the left upper quadrant area, which always radiates to the back. Okay, that's very important. The radiation is going to the back, okay, in order to differentiate it from the other abdominal pain. Okay, and most of the time, your patient will tell you your patient wants to sit and leans forward because it quite relieve the pain. Okay. Then there's also nausea, vomiting, tachypnea. Abdomen is usually tender with guarding but no rebound. Okay, so guarding. So sometimes you might mistake this as a surgical abdomen. Okay, so there's the difference between acute abdomen and a surgical abdomen. Okay, so for acute pancreatitis, the guarding here will give you idea that you're dealing with acute abdomen, but there's no rebound, so it's not surgical abdomen. Okay. There's also a fluid sequestration in retroperitoneum, which can be massive. Okay, in some books they will tell you the amount of fluid could be up to 10 liters, 5 to 10 liters. So that's very massive fluid loss in the retroperitoneum. That's why you have to one uh, one therapeutic treatment that you will do is fluid hydration. Okay? But 90% have mild and self-limited disease. But in severe cases, you will have Cullen and Great Turner sign, which are indicative of severe hemorrhagic pancreatitis. So Cullen sign is the bluish discoloration of periumbilicus. So think of Cullen and umbilicus. For Great Turner sign, these are bluish discoloration of flank. Okay? So Great Turners, you turn on your side or flank. Okay? That's how you will remember Great Turners. Think of turn on your side and flank. Okay? So that's the location of the discoloration. Okay, how you diagnose? There's you can request for amylase, which is secreted by the pancreas. Okay, but it was also found in salivary glands, small bowel, and other organs. Okay, so the amount, the level of amylase, which you can say that it is significant, should be 3 times the upper limit of normal. Okay, if it's 3 times normal, 3 times the upper limit of normal, it is 75% specific and 80 to 90% sensitive for pancreatitis. Still widely used because it's more commonly available than lipase, but high amylase associated with acute, not chronic pancreatitis. Okay, the other laboratory test is lipase. It is secreted by the pancreas due to the breakdown of triglycerides. Okay? Also found in gastric and intestinal mucosa and liver. So the level should be 2 times the upper limit. Okay? So the amylase is 3 times, but for lipase it should be 2 times upper limit in order it to be 90% specific and 80 to 90% sensitive. Okay? So, uh, and also, if you request for abdominal x-ray, you will see a sentinel loop, which has a distension, presence of air fluid levels there aside of abdominal distension. So in pancreatitis, it is secondary. Uh, so in pancreatitis, it is secondary to pancreatitis associated illness. So it's just an illness. Okay, ileus is different from intestinal obstruction. Okay, then there's also the colon cut-off sign on X-ray, okay, due to ileus also, and CT scan. Okay, you can diagnose. This is the diagnostic test of choice if you want to diagnose pancreatitis. Okay, but cost effectively, we do not request for CT scan right away if we're suspecting pancreatitis. Amylase lipase will do the diagnosis. Okay, this is a picture of a CT scan showing a well-perfused interstitial edematous acute pancreatitis. Okay, so this whole structure here is your. Can you see my cursor, Sophia? Hello, Sophia?
Yes po, Doc. We can see your cursor.
Hello? Hello, class?
Hello po, Doc.
Uh,
Makikita po namin.
okay. So, this whole thing is your pancreas. Okay? So, you can see here a interstitial edematous pancreatitis. Okay? with confluence of area of necrosis here, especially here in the neck and the body, pancreatic body. Also, there's a fluid surrounding the pancreas, and there's also a pancreatic, peripancreatic fat necrosis. Okay, the common, the popular risk stratification of pancreatitis. So the purpose of this is Ranson's criteria, or the risk stratification of pancreatitis is to predict the risk of mortality in pancreatitis. Okay, you can see the parameters: age, blood sugar, WBC, SGOT, LDH, which you should request during admission. Okay. Then after 48 hours, you have to request another laboratory. Okay, so the caveat of this Ranson's criteria is it's quite tedious, and you have to wait for another 48 hours in order to assess. That's the caveat of Ranson's criteria. Okay, this is the number of risk factors, then the percentage of mortality with the, according risk factors. Okay, another CT scan. Okay. So this structure, which is almost replacing your pancreas, is a picture of a pseudocyst. Okay. Later on, I will discuss the complications of pancreatitis. One of them is pseudocyst. This part is your stomach. Okay. So it pushes the antrum stomach upward, okay, causing somewhat obstruction in your stomach, upper GI obstruction. So this is a picture of pseudocyst complication of pancreatitis. Okay, let's go with the algorithm for acute pancreatitis. Okay, so I've taken up this algorithm from your Schwartz. Okay, so you will fit this in your Schwartz. So how you diagnose? It's easy to diagnose pancreatitis actually. Okay, there are only three criteria. This criteria is called the Atlanta criteria. So history of severe abdominal pain, okay, radiating to the back, is consistent with pancreatitis. Then you request for pancreatic enzymes like lipase, amylase. If 2 out of 3 is already present, you could already diagnose pancreatitis. So CT scan sometimes is required in order to confirm diagnosis. If the history is not congruent with the with pancreatitis, at the same time, if your pancreatic enzymes are not that highly elevated, okay. Then after establishing the diagnosis, these are your initial management. Give analgesia. Then fluid resuscitation. We talk about the fluid loss, approximately 10 liters if you have pancreatitis. Then you will make use of your risk stratification like Ranson's, HAP score, SIR score, SOFA, in order to predict the mortality of pancreatitis. Okay. Then reassess after 4 to 6 hours after initially giving your management. We had for hydration by measuring the mean arterial pressure, heart rate, urine output, hematocrit. Then after your patient has stabilized, you can request for your imaging. Okay? So you can request for ultrasound in order to know if it's due to a gallstone or sludge. Then you ask your patient regarding alcohol consumption. Diba? 100 to 150 grams in 2 years, grams of ethanol in 2 years up to 10 years. Then you could also request for MRCP or urgent ERCP if there's a presence of cholangitis. So cholangitis and pancreatitis might coincide. Okay? So you have to rule out cholangitis also if you have pancreatitis, especially if the cause of pancreatitis is due to gallstone. Then, if you know that your patient has severe pancreatitis with your risk stratification, you transfer your patient to ICU. Then, when initially you will order NPO, okay, nil per orem. But once your patient has uh, normobulimia, after 6 hours of fluid resuscitation, you may commence enteral nutrition. Okay? So, commence via nasogastric tube if there's no gastric stasis. Then, this is also a common mistake of clinicians. There should be no prophylactic antibiotics or probiotics. Okay? But once you have established the presence of infection already, you could give your antibiotics. But there's no prophylactic antibiotics in pancreatitis. Okay? Of course, you have to the approach in acute pancreatitis is called the step-up approach. Okay? You have to do conservative management and monitoring daily. Okay? We don't do surgery right away. Okay? So, surgery is ALAP. Okay? ALAP. As late as possible if you're dealing with pancreatitis. Okay? So, there. Indications for pancreatic protocol. Rarely in first week because we have to, the necrosis should be demarcated first before requesting for CT scan. Okay? So you can see in the algorithm, uh, if all things fail, okay, in 3 to 4 weeks, you can do surgical intervention like video-assisted retroperitoneal debridement, endoscopic debridement, okay? So indications for laparotomy, failed step-up approach, acute abdomen, especially if there's a perforation or ischemia, and severe abdominal compartment syndrome. Okay, this picture shows you the two minimally invasive interventions for local complications of acute pancreatitis. Okay, uh, so this picture here is okay. This one rather. Okay, so this one rather is a video-assisted retroperitoneal debridement. So, with the use of CT scan, you approach the necrosis at the back because your pancreas is retroperitoneal. Okay? Then you make a small incision, then you remove as much as you can, necrosis as you can. Okay? Necrosectomy. This picture is a endoscopic transgastric necrosectomy, another minimally invasive intervention. Okay? So, we make use of gastroscope with special instruments. You open the posterior portion of the stomach, then you can already approach the necrotic part of the pancreas. So the pancreas is located just posterior to your stomach. Okay? So what are the complications of acute pancreatitis? There's the local, okay, phlegmon, abscess, pseudocyst, ascites, and also the systemic complications of pancreatitis. Okay, let's go with the terminologies in order for you to understand. Okay, so these are the local complications of acute pancreatitis. So we call the fluid around the pancreas, if it's within 4 weeks with no defined wall, it is called, the fluid is called acute pancreatic fluid collection. Okay, APFC. And if the fluid is combined with solid within 4 weeks, okay, it's called acute necrotic collection. Okay, so the important thing is here is the time frame. It should be less than 4 weeks. If it's already more than 4 weeks, you could see a defined wall of the necrosis. Okay, the fluid collection is already called pseudocyst. It's no more called a acute pancreatic fluid collection. It is already called pseudocyst. Okay, class. And the solid necrosis combined with fluid, it is already called walled off necrosis because it's already has a defined wall. That's why it is called walled off necrosis 1. It's no more called a acute necrotic collection. Okay. Okay, once again, these are the different terms of pancreatic fluid collection. Peripancreatic fluid, talk about this. Acute pseudocyst, so there's already pseudocyst is also classified. It could be acute or chronic. And one complication of pancreatitis also is pancreatic abscess. Okay, so let's proceed with the chronic pancreatitis. Okay, so chronic pancreatitis is most commonly in alcohol abuse. So gallstones are not a common cause of chronic pancreatitis. Other etiologies, hyperparathyroidism, cystic fibrosis, not common to us, congenital pancreatic anomalies, hemochromatosis, and also associated with chronic liver disease. Signs and symptoms of chronic pancreatitis. Okay. The most disturbing signs, the symptom of chronic pancreatitis is pain. Okay. Then you will have malabsorption, steatorrhea, elevated blood sugars, and colic. So that's the most striking symptom. It's pain. Okay, that is always present in chronic pancreatitis. Then how do you diagnose chronic pancreatitis? Okay, history is very important. You have to know the alcohol consumption. Then on X-ray, you can see pancreatic calcifications. And if you perform ERCP with pancreatography or MRCP, you could see chains of lakes over the pancreas, meaning there's a calcifications and dilatations of pancreatic duct. And you could also sometimes see complication of chronic pancreatitis, which is cirrhosis. Okay, this is a picture, a CT scan picture of a chronic pancreatitis. You can see the white portion here are the calcifications or stones inside your pancreas, inside your pancreatic duct. Okay? Normally, the pancreatic duct cannot be visualized, but in this picture, in this patient, you can see the pancreatic duct, meaning the duct is dilated. Okay? So how do we treat chronic pancreatitis? Of course, there's the non-operative management. You control the pain, and you also address the endocrine and exocrine insufficiency. Okay. Ampullary procedures, you could do uh, uh, opening of the ampulla, ampulectomy, then you extract the stone. Okay, you could do drainage, ductal drainage, ablation, and for pseudocysts, okay, for the complication, most of the time pseudocysts is self-limited. Okay, so you don't perform, you don't do surgery within 4 weeks of the pseudocyst because first, it might be a self-limited pseudocyst. Second, the wall of the pseudocyst is not mature enough. Okay, if you perform surgery with a pseudocyst wall not matured, okay, you will have a leak. Okay, if you perform cystogastrostomy or a cystojejunostomy, you have the wall of the pseudocyst should be matured prior to gastrostomy, cystojejunostomy. So that's the two reasons why we don't perform surgery within 4 weeks. First, might be self-limited. Second, the pseudocyst wall is not mature. Okay, indications for surgery: persistent pain. Sorry. Indications for surgery: persistent pain, gastrointestinal or biliary obstruction. Okay, there's already a stone inside your pancreatic duct, a pseudocyst infection, and an enlarging pseudocyst. So this is a picture of cystogastrostomy. Remember, the pancreas is located posterior to your stomach. Okay, so if the pseudocyst is adherent to the posterior portion of the stomach, you could already create a connection between the posterior wall of the stomach and the pseudocyst. So this is what you call cystogastrostomy drainage. Okay? There's also a technique called the Endoluminous Systogastrostomy. This is an endoscopic procedure with the help of endoscopic ultrasound, which will guide you puncture the pancreatic pseudocyst, and you will place a stent in order to maintain the connection. Okay, this is an open surgery where you have to open the pancreas and as well as the pancreatic duct in order to extract the pancreatic stone, the stone inside your pancreatic duct. Okay, that's what you call pancreatitis of pancreatic stone. Once you open it up, you have to perform. You have to connect it with a portion of jejunum. So it's called pancreatico-jejunostomy, popularized by Puesto. That's why it's called Puesto procedure. Okay, these are the tumors of the exocrine pancreas. Okay, first the benign, which are serous, mucinous, IPMN, and mature cystic teratoma. Okay, so for the serous, mucinous, IPMN, these are cystic uh, tumors, lesions of pancreas. Okay. But for the borderline, mucinous cystic, so between the serous and mucinous, okay, mucinous as the is already considered a pre-malignant tumor. Okay? As well as intraductal papillary mucus tumor, IPMN, and a solid pseudopapillary tumor, or also called as Franz tumor. Then we have this malignant tumor, ductal adenocarcinoma, serous mucinous cystadencarcinoma, intraductal mucinous papillary. Okay, let's proceed with the first malignant tumor of the pancreas. So it's mainly an exocrine. Okay, so if I ask you in your exam if adenocarcinoma is an exocrine and endocrine is an exocrine. Okay, so it's most commonly located in the head of the pancreas, and also we already established the connection of smoking with this adenocarcinoma. What are the signs symptoms? Weight loss. Okay, always remember if you're dealing with a patient with intentional significant weight loss, you're dealing most probably with the malignant one. Okay, so your patient will present with jaundice due to obstruction in the head. Okay, if your pancreatic adenocarcinoma is located in the head. Okay, but if you have adenocarcinoma located in the body and tail, okay, your patient will not present right away with jaundice. Okay, so my question is, Sujit,
Yes, coach.
okay, so my question is, between adenocarcinoma and head of the head and adenocarcinoma of the body and tail, which has better prognosis based on your readings, because you are the reporter in our ward work with this topic. So based on your readings, which has better prognosis, pancreatic head or pancreatic body and tail adenocarcinoma?
Doctor, here.
The head.
Yes.
What's the reason why? Yes, you're correct. Okay, the pancreatic head adenocarcinoma has better prognosis than the body and tail. So what's the reason why does it have a better prognosis? There should be a reason, okay? You know the reason?
I think, doctor, in there is a that site is a independent prognostic factor. That's why, and for survival rate is good in head site.
Survival.
Yes.
That's the reason. But they have same histopathologic uh, uh, pathology, which is the adenocarcinoma. So I think that's the reason why.
And I think in tail side, adenocarcinoma is defined lead.
Yes, it's in the left.
Defined lead.
Define. Okay, you're saying that the detection in body and tail is late. Why is it detected late? Okay, you're in the right track, Sujit. Why is it detected late? I have already given you the answer. If you're listening to me a while ago. Why is it detected late? Sujit, you know the reason? Okay, how about Vaishnavi? Vaishnavi, are you there?
Yes, Doc.
Okay. So, are you listening to my question to Sujit? So, what I agree with Sujit, okay? Pancreatic head has a better prognosis because body and tail adenocarcinoma is detected late. Okay? Why is it detected late? What's the reason? Okay, I will tell you the answer. Okay. Body and tail are detected late. True, it is true, Sujit. Because I mentioned a while ago that jaundice, okay, sits in later part of the disease if it's located in the body and tail. But if it's located in the head of the pancreas, okay, there will be jaundice right away. Even if the tumor is very small, it will obstruct your biliary tree causing jaundice. That's why there's an early diagnosis, early detection of pancreatic head adenocarcinoma. Okay? So that's the reason of better prognosis. But if your patient has already pain radiating to the back, okay, which is common to your body and tail adenocarcinoma, that's the common symptom of pancreatic adenocarcinoma in body and tail. Pain radiating to the back, meaning there's already encasement of the celiac plexus. That's why the pain is very striking. Okay? So at this time, you will the tumor in the body and tail is already unresectable because it's already encased the celiac plexus, causing pain. Of course, there's also phlebitis in pancreatic adenocarcinoma. Okay, diagnosis. Tumor marker, okay. Elevated CA19-9, elevated alkaline phosphatase, and direct bilirubin due to obstruction. If if your patient is already jaundice, you can request for ultrasound. But for in my practice, I go right away with CT scan. Okay, the proper CT scan request is triphasic CT scan of the abdomen, pancreatic protocol. Okay, then you can also request for PTC or endoscopic cholangiopancreatography or ERCP. So we have to classify if the tumor is resectable, uh, locally advanced, or metastatic. Okay. So by just requesting for a very good high quality imaging like CT scan or MRI, we could already establish resectability. Okay. Uh, but sometimes if this CT scan is not a high quality or is not a pancreatic protocol, resectability is assessed intraoperatively. Okay? So what defines surgical resectability? So potentially resectable, we label this as potentially resectable because we don't know if you have requested a good quality CT scan or not. So upon potentially resectable, meaning there's no SMA celiac axis involvement. The SMB also, the vein, portal vein is also patent. And there's no distant metastatic disease. But for locally advanced, there's already abutment casement of SMA, celiac axis, occlusion of SMB and portal vein, But sometimes locally advanced could also be. It doesn't mean that there's distant metastatic disease. Sometimes it doesn't have metastatic disease yet. So for the treatments, let's go with the treatment. Of course, most of your patient uh, significant weight loss. That's why we have to do surgical nutrition build up. Okay, pre-operatively done. Okay. Um, Cholangitis, okay, it rarely sits in patients with pancreatic adenocarcinoma. So it is not a gold standard. It's not routinely done. Biliary decompression is not routinely done in pancreatic adenocarcinoma. Okay, it is just reserved for patients with cholangitis due to a pancreatic tumor. Okay, if your patient has a resectable tumor, okay, the very popular procedure here is a Whipple's procedure. Whipple's procedure o pancreaticoduodenectomy. Okay? But if it's unresectable, we could do palliative procedure. We could relieve the biliary obstruction by ERCP or PTBD. And there's also a obstruction in the duodenum. We could perform open bypass, or we could insert a duodenal stent. Okay. For pain, we could inject uh, lidocaine in the retroperitoneum, causing splasticectomy. Okay. In Whipple's procedure, what we remove are the gallbladder, common bile duct, antrum of stomach, duodenum, proximal jejunum, and head of pancreas. Okay? These are removed and blocked, meaning we don't remove these parts one by one. They are removed as one, all in one. Okay? So this Whipple's procedure is associated with high morbidity and high mortality. That's why pre-operative uh, patient selection is very important. So this algorithm is also in your Schwartz. Okay. So if you are entertaining, if you are if you have already inkling with you're dealing with the pancreatic tumor, you request for a very good CT scan, high quality, then you can already assess if it is unresectable or resectable. Okay. If it's resectable, you could do diagnostic lab, Whipple procedure, or EUS. Okay, so EUS biopsy is the proper uh, uh, biopsy of choice in pancreatic tumor. Okay, so EUS biopsy is reserved for those tumors with borderline resectability. Okay, we have also this what you call borderline resectable. Okay, aside from resectable, we have this borderline resectable and unresectable. So this borderline resectable, we perform EUS biopsy in order for you to, in order for your patient to undergo neoadjuvant clinical trial or chemotherapy. So if your patient is subjected to chemotherapy, granting that the tumor has shrink and you can perform surgery, okay, so you proceed with your Whipple's procedure. But if it is unresectable based on CT scan, you could also perform EUS order to keep clinical trial, but it doesn't change the mortality rate. So these are the steps, clockwise steps of pancreatic duodenectomy. First, the exposure of intrapancreatic SMB. Okay. By exposure of the SMB, we could already assess if it's already resectable. Then you proceed right away with extended Coker maneuver. Okay, you mobilize the duodenum, entire duodenum from the retroperitoneum. Then proceed with the portal dissection. Okay, you perform in this portal dissection. You perform cholecystectomy and transection of the common hepatic duct. Okay, this portal dissection doesn't include portal vein dissection. Okay, it doesn't mean that you have to cut the portal vein. This portal dissection meaning you have to do cholecystectomy and uh, bile duct transection. Then next is you transect the stomach. If you will perform a classic Whipple's procedure, you transect the stomach and the antrum. But if you are planning to do a pylorus preserving Whipple's procedure, okay, you preserve the pylorus. Okay, you just transect uh, right below your pylorus. Then you proceed with the transection of the jejunum and dissect the ligament of trites in order to mobilize the jejunum and the last portion of your duodenum. Then lastly, you transect the pancreas. Okay. So where do you transect your pancreas? At the neck. Okay. Just above your SMB and SMA. Okay, after transecting, after doing the resection part, first part of your Whipple's, which is the resection part, you perform the uh, reconstruction part. Okay, first you perform the pancreatic jejunectomy. Okay, you connect the remaining body and tail of the pancreas to a portion of jejunum. Then you have to reconstruct the biliary tree by performing cholecystectomy or hepatic jejunectomy. Then lastly, you will connect the duodenum if you do pylorus preserving, or if you did a distal gastrectomy, which is the standard Whipple's, classic Whipple's, you perform gastrojejunostomy. Okay, the next malignant tumor of the pancreas is cystadenocarcinoma. Okay, it composes of less than 2% of all pancreatic exocrine tumors. Also presents with abdominal pain. It has a better prognosis than adenocarcinoma. Same thing, since it is located in the body and tail, we could perform surgical resection by distal pancreatectomy, okay, leaving the pancreatic head. So it's more common in the body and tail. Cystadenoma, okay, so it's common in older and middle-aged women, also presents with abdominal pain. There are two main types, serous, which is a benign, and mucinous, which has a potential to be malignant. Okay, so think of mucinous, malignant potential. Same thing, the treatment is surgery. Insulinoma, overproduction of insulin, which is common in the which is the most common islet cell tumor. Okay, so but 85% are benign. Then your patient will suffer from spells or blackouts due to hypoglycemia. Okay, so if the treatment here is you give sugar in order to correct the hypoglycemia. Okay, so how you diagnose insulinoma? We have this people's triad, okay, which is also a favorite board question. First, the symptoms of hypoglycemia with fasting is present. Then the level of glucose is less than 50. And this hypoglycemia is relieved with the giving of glucose. So that's the Whipple's triad in order to diagnose insulinoma. Okay, guys, are you still there? Sophia?
Yes po, Doc. Nandito.
Okay. So, insulinoma. So, how you diagnose insulinoma? Fasting serum insulin, okay, if it's more than 25, because normal is less than 15. Surgical resection is also uh, curative. Okay, gastrinoma, overproduction of gastrin, also known as Zollinger-Ellison syndrome, which is a part of your MEN1. Okay, diagnosis here is fasting serum gastrin. Treatment is you give PPI, which is omeprazole, and also we could do surgery in some cases. Okay, this picture is in your book, Schwartz. Okay, this is the Pasaros triangle. Okay, so sometimes in exam I will ask you the boundaries of Pasaros triangle. Okay, so this is the typical location of gastrinoma, including the head of the pancreas, duodenum, and lymphatic bed posterior, superior to the duodenum. Okay, I might give this in your exam. I ask the borders of the Pasaros triangle. Okay, let's proceed with the lymphoma. Okay, this is the overproduction of vasoactive intestinal peptide (VIP), also known as Vermeer-Morrison syndrome or WDHA, because the symptoms here are watery diarrhea, hypokalemia, achlorhydria. So most are malignant, which majority has metastasized already at the liver at the time of diagnosis. So as okay, mentioned a while ago, the symptoms are watery diarrhea, hypokalemia. If you get the serum BIP level, it should be more than 800. The normal is less than 200. The treatment here is surgical resection, chemotherapy, and octreotide, which is a somatostatin analog. Okay, the second part of our lecture is about spleen. Okay, so what is spleen? Is an immunologic organ. Okay. 20% of patients have accessory spleen. Okay, the enlargement of the spleen, physical enlargement of the spleen is called splenomegaly. Okay, so you could already palpate the spleen in the left subcostal margin. The main cause of splenomegaly are disease states that can be transient. Okay, and this could be disease states can be primary or conditions associated with hypersplenism. So don't be confused with Splenomegaly and hypersplenism, okay, they are not interchangeable. Okay, they are not the same. Because hypersplenism is only one cause of splenomegaly. And it refers to the increased destruction of blood cells by the spleen. So, splenomegaly alone is not an indication for splenectomy. Many conditions that cause splenomegaly are benign and non-shared. Okay, so let's proceed with hypersplenism. As I've said a while ago, it is the excessive removal of any and all circulating blood elements. It's classified as primary or idiopathic and secondary. So hypersplenism, actually primary hypersplenism is very rare. So it is a diagnosis of exclusion and more common in women. These are the different causes of etiologies of hypersplenism. Secondary hypersplenism, which is more common than the primary. First, the hemolytic anemia. Okay, you have this spherocytosis, hereditary erythrocytosis, GSXPD, thalassemia, sickle cell, idiopathic autoimmune hemolytic anemia, ITP, and TTP. Okay. Then you have this neoplastic and myeloproliferative stage, which are lymphoma, leukemia, CML. Hypersplenism with chronic due to a chronic inflammatory diseases, Filthy syndrome, sarcoidosis, SLE. Okay, sometimes the splenomegaly is due to a portal hypertension. Okay, but portal hypertension is the okay. So portal hypertension is the most common cause of hypersplenism. Okay, so if in the exam I ask you what's the most common cause of hypersplenism, the answer is portal hypertension. Infections could also cause hypersplenism. Okay, mononucleosis, endocarditis, parasite, fungus, TB, and some storage diseases or metabolic abnormalities. Okay, let's proceed with the treatment. Okay, so splenectomy is absolutely indicated for primary hypersplenism. But for secondary hypersplenism, like those diseases I mentioned a while ago, it is only relative indication. Okay, so patients who undergo splenectomy for some reasons uh, should also receive vaccinations for pneumococcus, haemophilus, and meningococcus. Okay, these are capsulated bacteria, which if you already have doesn't if your patient uh, doesn't have spleen anymore, these capsulated bacteria are common cause of infection. So indications for splenectomy: first, trauma, splenic rupture. Okay. Then you have your hereditary spherocytosis, primary tumors, parasitic cyst, splenic abscess, ITP, refractory TTP, symptomatic splenomegaly. So, what are the common conditions associated with ruptured spleen? Not only for trauma, you could also have bacterial infection like mononucleosis, malaria, and also splenic abscess. Complications on splenectomy, atelectasis, okay, because spleen uh, is adherent to your diaphragm. Your patient might not be breathing well, causing atelectasis, okay. Pneumonia, pleural effusion, overwhelming post-splenectomy sepsis or infection, OPSI. Okay, this is the most popular complication of splenectomy. Okay, so what is OPSI or overwhelming post-splenectomy infection? The organisms causing this OPSI are namely Streptococcus pneumoniae, H. influenza, Neisseria meningitidis, Streptococcus species, Salmonella, Capnocytophagia canimorsus or from a dog bite. So that's why if your patient, if the splenectomy is elective, okay, meaning it is scheduled, you can give these vaccines 2 weeks prior, okay? But that's the recommendation, okay? But if your patient underwent an emergency splenectomy, okay, you could give your vaccines 2 weeks or within admission. Okay, 2 weeks after splenectomy or within admission. So these are the uh, vaccines that you will give for patients who have undergone splenectomy in order to avoid this OPSI. Okay? Remember this class, okay? The organisms and the vaccines. Let's proceed with the malignant tumors of the spleen. Okay? First is the Hodgkin's lymphoma, which the hallmark of this is the giant multinucleated Sternberg cells. If you will see it in a microscope, okay? Classifications, you have four major classifications: nodular, lymphocyte predominant, mixed cellularity, or lymphocyte depletion. Okay. The adverse prognostic factors in Hodgkin's diseases includes a bulky mediastinal disease, age more than 40, male gender, and a significant weight loss and fevers. So staging in Hodgkin's lymphoma can be done clinically or laparotomy, which is more accurate. So the reasons for staging is that lesion usually starts as a single focus and spreads along adjacent lymphatic channels. Okay. So lymphoma, so it will spread along lymphatic channels. So prognosis is directly related to clinical stage. Okay, so therapy is dependent on what stage. So that's the key there. Okay, so clinical staging by laboratory values and radiographic studies are inaccurate. Okay, so the more accurate one is a laparotomy staging. Okay, so treatment for stages 1 and 2. Okay, we could consider radiation alone, but for advanced stages, you can add chemotherapy. Okay, let's proceed with non-Hodgkin's lymphoma. Okay, so these are the systemic disease at the time of diagnosis. Primary disease limited the spleen is rare. Okay, sometimes you will have superior vena cava syndrome, fever, weight loss, or body malaise. So the treatment here is also chemotherapy. Splenectomy has a limited role in the management of non-Hodgkin's lymphoma. Okay, ITP or idiopathic thrombocytopenic purpura. The etiology is unknown. The signs and symptoms are petechiae, purpura over trunks and limbs, guaiac positive stool due to a mucosal bleeding. Okay, so the diagnosis is through a complete blood count, which reveals thrombocytopenia. The treatment, okay, you could give corticosteroid, intravenous immunoglobulin, for severe cases. Platelet, okay, remember this, you can give platelet transfusion, okay, especially if there's a significant bleeding. So 1 unit of platelets increases platelet count by 10,000. Okay, so you compute the amount of units of platelets that you will give. So it will take a few weeks to resolve, and caution against strenuous activity. Okay, let's proceed with the TTP, thrombotic thrombocytopenic purpura. Okay, it's a hemolytic anemia that results from deposition of abnormal von Willebrand factor, multimers into microvasculature. So the diagnosis for TTP are dyspentad, what RN, okay? Fever, anemia, thrombocytopenia, renal dysfunction, and neurologic dysfunction. Okay, unlike ITP, okay, idiopathic, thrombocytopenic purpura, for TTP, thrombotic thrombocytopenic purpura, we do not transfuse platelets, okay? Because transfusing platelets in TTP is thought to fuel the fire and exacerbate consumption of platelets and clotting factors, which resulting in more thrombi in the microvasculature. So we do not transfuse platelet. So what is the treatment? Plasmapheresis is the mainstay of treatment. You may give FFP if plasmapheresis is not available. Okay? You could also transfuse PAP-RBC. You could give corticosteroid, vincristine, antiplatelet agents, and some cases we could also do splenectomy. Okay? Most patients are admitted at the ICU. Okay? So that's the end of our lecture for today about pancreas and spleen. Okay, class, any questions, clarifications? Sophia, any questions?
Wala naman.
Okay. Actually, the lecture of Sujit is quite good. You could also use that as your reviewer for the reviewer for the exam that I will give you. Okay. So, Sophia, can we have our shifting exam tomorrow earlier at around probably 9 o'clock? Can we do that?
Doc, I'll check for the schedule po and we'll update you.
Okay, if you are not available around 9 o'clock because I have surgery 10 o'clock and I have something to do in the afternoon, we could reschedule the exam. Okay? So, if there's no more questions, Sujit, you have questions? Okay. So, I've already given you the important things that you will remember that I might give in your shifting exam. Okay. So, if there's no more questions, clarifications, let's call it a day. Okay. Thank you and goodbye.
Thank you po.
Thank you, guys.